Hi, everyone. Welcome. My name is Melanie Kress, and I am the Associate Curator for Highline Art, the public art program presented by the Highline in New York City. I want to welcome you all and thank you for joining us for the sixth and final conversation in our speaker series, The Normalizing Gaze, Surveillance from Drones to Phones, this event titled Public Health, Privacy, and Surveillance. This series is organized in conjunction with artist Sam Durant's Highline Plinth Commission Untitled Drone, which opened this past spring and will be on view on the Highline at 30th Street through August 2022. Untitled Drone is a large-scale fiberglass sculpture in the shape of an abstracted drone sitting atop a 25-foot tall steel pole. This work continues Highline Art's mission of presenting new, powerful, thought-provoking artworks that generate and amplify some of today's most important conversations. Inspired by this artwork, the speaker series brings together artists, activists, scholars, filmmakers, and journalists to demystify the twinned histories of surveillance and drone warfare and to illuminate routine examples of surveillance in our daily lives. The Normalizing Gaze is presented by the Highline and the Surveillance Technology Oversight Project, a nonprofit advocacy organization and legal services provider that litigates and advocates for privacy, working to abolish local government systems of mass surveillance. As we begin, I have a few announcements regarding the logistics of the event. These will also be included in the chat. Throughout the presentation and discussion, we encourage you to ask questions. Please use the Q&A feature at the bottom of your screen. We will select from your questions for our moderator. If you would like to use closed captioning, please go to the button at the bottom of your screen and click on the CC option. Here you will be able to turn on the caption. If you have any technical questions, you can also put them in the Q&A. And lastly, in the coming days after the series, a recording of this event will be posted on the Highline's website for future viewing. Although we are in virtual space together, before we get started, I would like to acknowledge that I come to you from Brooklyn, New York, on the ancestral land of the Lenape and Canarsie. If you are interested in finding the name of the indigenous people whose land you may live on, please visit the link in the chat. And I would now like to introduce our event moderator, Cheryl Gay Stolberg. Cheryl is a Washington correspondent covering health policy for the New York Times. Since joining the Times as a health writer in 1997, she has held a broad and varied career, including covering Congress and the White House during the administrations of Presidents George W. Bush and Barack Obama, as well as national politics. Cheryl returned to health writing at the outset of the coronavirus pandemic and now focuses on the intersection of health, policy, and politics. Previously at the Los Angeles Times, she shared in 2 Pulitzer Prizes won by that newspaper's Metro staff. Cheryl, thank you so much for being here, and please join us.
Thank you for having me, and welcome everyone. I'm super excited about this talk. I know that it's going to be so interesting. I would like to start by introducing our panelists. First, Dr. Renee Nahera, sorry, Renee. He is an epidemiologist and editor of the History of Vaccines project by the College of Physicians of Philadelphia. Renee graduated with a Doctor of Public Health degree from Johns Hopkins University Bloomberg School of Public Health in 2018. He's worked for local and state health departments as an epidemiologist and a program manager, and with the CDC in response to the Zika epidemic in Puerto Rico. He is originally from Mexico, and he immigrated to the United States when he was 10. Beth Blauer, our next panelist, is the Associate Vice Provost for Public Sector Innovation at Johns Hopkins University. She is the former Executive Director and co-founder of the Centers for Civic Impact at Johns Hopkins. As a dedicated public servant and international expert on government performance programs for more than 15 years, Beth has spent her career working to improve people's lives by bringing data into government's decision-making processes. And last but not least, Adam Schwartz is a senior staff attorney at the Electronic Frontier Foundation. He advocates against surveillance and censorship in courts and legislatures. Before joining EFF, Adam worked as a senior staff attorney at the American Civil Liberties Union of Illinois. He graduated in 1995 from the Howard University's School of Law. And with that, I'd like to just kind of set the table for us a little bit and share with you some things that I've been thinking about. The coronavirus pandemic has presented us with an entirely new set of questions about personal liberty and privacy versus the rights of the state. And broadly speaking, I think the question before us tonight is this: does the safety of the community supersede personal liberty when everyone is at risk from a communicable disease? In many ways, this echoes the debate we had after 9/11. Those of you who are old enough to remember 20 years ago will remember that Congress at that time considered the Patriot Act to basically assert the right of the government to collect information on American citizens in the name of national security. And this is all part of a much bigger debate that we are having as a country about how people get to control their own healthcare information. I've been reporting on these topics for more than a year now, coming up almost on 2 years with the pandemic. And I see this tension playing out in two distinct areas. First, does the government have the right to compel people to act, as in the case of mask and vaccination mandates? And second, does the government have the right to collect personal data about infection and vaccination, or to require people to show proof of vaccination through so-called vaccine passports? And I wanted to start first with that idea of mandates. Public health experts will tell you that in an infectious disease outbreak, when everybody is at risk, the steps that we take to protect ourselves, like wearing masks and vaccination, are also steps that we take for the greater good to protect society. People who argue that they cannot be compelled to either wear a mask or take a shot because it's an intrusion on their personal liberty are bumping up now against those who say, your right to liberty ends where my right not to get killed by an infectious disease begins. And I recently got in trouble with Fox News for saying this very thing in an interview on MSNBC. They called me out on it. Generally speaking, courts have upheld the state's right to protect the public in an infectious disease outbreak, either through quarantine or other means, including vaccination. In 1905, the Supreme Court upheld the right of the state of Massachusetts, or I think it may have been actually the city of Cambridge, to require smallpox vaccination. And Justice John Marshall Harlan wrote at that time that, quote, a community has the right to protect itself against an epidemic of disease, which threatens the safety of its members. And that is how states have been able to mandate childhood vaccinations. We're having a big debate about whether or not we should be mandating coronavirus vaccinations, but every state already mandates vaccinations against childhood diseases like measles and mumps and rubella. Mississippi, for instance, which has one of the lowest COVID vaccination rates in the country, has one of the highest childhood vaccination rates for one reason: it doesn't allow religious exemptions. Jacobson and a couple of other suits that followed it, though, don't lay any legal groundwork for a national vaccine mandate. And in the US, vaccination is the province of the states. That's why we saw the president failing to impose a national mandate. He can't. Instead, he took kind of limited actions involving employers and federal workers, et cetera. Now, a bit about data gathering. The pandemic, and I know you're going to hear this from Beth, has exposed serious flaws in our system for gathering data about infection. If you've followed the news early in the pandemic, you saw that South Korea was widely hailed for controlling the outbreak and limiting infections and deaths. But a big untold part of that story was that the South Korean government is able to harvest and disclose vast amounts of personally identifiable data, credit card data, mobile phone data, et cetera, which it used to track down people and test them and quarantine them. And I don't think that would fly in the United States. Here, the system is patchwork at best. Like vaccination, data gathering is the province of the states, and different states collect information in different ways, some more detailed than others. And that has left it to news organizations like my organization, the New York Times, and academic institutions like Johns Hopkins to collate data from the states into some kind of national picture about what's happening with the pandemic. Meanwhile, though, states are already collecting data on vaccination. Every state has a vaccine registry that collects information on who is vaccinated against what disease. And IT companies are already working with states to gather the information for them. But the registries don't talk to each other. And with COVID, for the first time, the Centers for Disease Control raised the idea of taking it one step further, and they required states to sign data use agreements to turn over their information, including names, address, race, and ethnicity of vaccination recipients to the federal government for what really amounted to a national registry. And some states balked. Andrew Cuomo, when he was still governor, told me that, New York wasn't going to turn over this data. He saw it as kind of just another way to let the government track people and perhaps track undocumented citizens or undocumented residents. They're not citizens. So when you see this outcry over vaccine passports, electronic apps that show proof of vaccination, it's important to remember that states already have this data. And so the question is really over whether or not there ought to be a requirement to show proof and how people can control their own healthcare information. It's not a surprise, I think, to anyone that in the era of Donald Trump, all of these questions have become politicized, with Republicans generally arguing that the rights of the individual trump, no pun intended there, trump the rights of the government, and Democrats generally arguing that the safety of the community is paramount and must come first. And in many of these cases, and I think we'll hear from Renee about this, it will be up to the courts to decide. And so with that, I'm going to turn it over to Renee, who's going to give us a historical perspective. He will be followed by Beth, and last but not least, Adam.
Hi, Cheryl. Thank you for that. And I won't hold it against you for mispronouncing the last name. Everybody gets it wrong. Good afternoon, everybody. Thank you for joining us. I'm very, very happy to be here with you and to talk to you about this, about the history of vaccination with regards to vaccine mandates and vaccine passport requirements. Passports, I'm going to put it in quotes because it wasn't always passports. And even to today, it's not really a passport. It's more of a certificate, a confirmation that you've been vaccinated. The history of this goes back to before we had vaccines, before we had the first vaccine in the late 1700s created by Edward Jenner against smallpox. Before then, the best fight against smallpox, which was this terrible, horrible disease that if you ever have seen anybody with smallpox, you will never, it gets seared into your mind. The first fight against that was inoculation, which was finding a strain of smallpox that didn't cause severe disease, either drying it in the sun or giving somebody a very small amount under the skin, and that would give them smallpox, but in a very limited way. They would develop some pox here and there, but they would generally recover. And the first people to do this were the Chinese, and then the practice moved along the Silk Road into the Middle East, into Northern Africa. When it gets to Northern Africa, people who were enslaved in Africa and trafficked in the slave trade would be given that inoculation as a way to have them be worth, if a human being can be worth anything or more than others, have them be worth more. And so an enslaved person who had the mark on their arm that they had the inoculation would be worth more to the trafficker than anybody else. And so that was the first quote unquote passport as far as a vaccine went, because if they were going to be trafficked, they would prefer to have somebody who had that practice done to them in Northern Africa. Then it moved to Western Africa, and then this practice moved to the Americas through the knowledge of an enslaved man by the name of Onesimus into Massachusetts, which is a whole other story. And then that was the one way to confirm this. When Jenner develops the vaccine, the smallpox vaccine, then we get into the government, or the governments at the time, the governments of the world, trying to figure out a way to make sure that people had the vaccine. And again, they relied on the scar because it was a very noticeable, very distinct scar from that left by other inoculations. And so people would just show, hey, I have the scar, I have the smallpox vaccine scar. I wasn't privileged enough to get the vaccine. I was a little bit late to the party after eradication of smallpox. But folks who were born, before 1970 or so in the United States would probably have that scar to this day. So we move into the 1850s. In the 1850s in Massachusetts, the smallpox vaccine is required for attendance to school. and children are enrolled into a sort of a registry to keep track of who has it. They're not just relying on the arm scar, but they're also relying on this government maintained registry at the school level. So, oh yes, little Johnny had his smallpox vaccine, come on right in. Oh, you didn't get your smallpox vaccine? Sorry, you can't go to public school, you have to go get it. And so we move into the era of these vaccine mandates in schools. Generally they're agreed upon, but as Cheryl mentioned, Jacobson versus Massachusetts in 1905, a man by the last name of Jacobson didn't want to get the smallpox vaccine. He felt that he was already protected from smallpox because he claimed to have had smallpox as a younger man. And the city levied a fine against him, and he took it all the way to the Supreme Court. The Supreme Court said that in the police powers given to the state and to the local governments, they were able to fine him. They couldn't hold him down and give him the vaccine. That would be a violation of his person, but they could fine him for not getting the vaccine. Similarly, with school requirements in Sugg versus King, the Supreme Court again reaffirmed that, saying, well, the school, that you need to protect the children from these diseases. And to do that, the school is making a reasonable requirement for vaccination. Then, go ahead and keep on that requirement. And then once more in Prince versus Massachusetts seems to be the epicenter of all of this. In Prince versus Massachusetts later on, not directly associated with vaccines, but tangentially mentioning, the justices mentioned vaccines in their ruling, that the religious beliefs of a parent did not supersede the right of the child to be safe. And so that included vaccination. So we have these 3 Supreme Court cases, a long history, that say, the state can require these things, including quarantine and isolation for people with the disease, vaccination for children to go to school or to receive anything, any kind of public service, or for people to travel. And that was within the states. Again, in the United States, this is how it's set up. Other countries are more at a federal level. So in 1897, India has an outbreak of the plague, the bubonic plague, Yersinia pestis, and they have a crude vaccine that wasn't the best vaccine, but it was the best that they had at the time. And they required it of people to travel, to break quarantine. If they were in a quarantine area, if you had the vaccine, then go ahead and get it. The problem was that vaccine was also known to give very bad side effects. This is the early days of germ theory. This is towards the end of the Pasteur era of vaccination and almost the beginning of the viral era of vaccinations. And so Valdemar Haifke, he develops this vaccine, takes it to India. They require it of people. People don't want to get it because they've heard of the bad side effects, because they have their own beliefs about their body autonomy. And the British come down hard. The British colonial authority comes down hard on people who will not vaccinate, going as far as to burn down their houses out of fear that the plague would be transmitted by inanimate objects within the house. We know now that the plague is transmitted by fleas and rats. And so they do all these atrocities, and they require this vaccine certificate. In India, 12 million people died from this outbreak, and in the rest of the world, between 1 and 2 million people died. So it was pretty bad there. And so they had these curfew passes that if you had the pass, you could break quarantine, you could go out, you can go to your festivals and et cetera. But not a lot of people had them because they weren't accessible. Interestingly enough, if you were European or British, you didn't need those curfew passes. You could just go right ahead because you were clean, because you didn't live in crowded spaces like the people from India did. And so, that's a disparity that if it echoes to today, it's because history seems to repeat itself. Then in the 1930s, we get the yellow fever vaccine. Yellow fever is a viral infection that is transmitted by mosquitoes, mostly in the tropics around the world. And the World Health Organization in the 1950s said, if you're going to travel to these places that are highly endemic for yellow fever, then you should present a yellow fever vaccination record upon arrival, because they wanted to stop the spread of this disease the world over. And so when you arrived at these countries, you show your vaccine record, the yellow certificate or the yellow passport or the yellow ticket, as it's called, and you can enter the country. A lot of opportunity for fraud there, where you would be sold one before you got to customs. Then the smallpox certificate was also used in certain countries to prevent smallpox from spreading, especially during the eradication campaign that started in the 1950s and went all the way into the 1980s. By 1981, you didn't need the smallpox certificate anymore. Currently, you need the yellow fever vaccine for some countries. You need the meningitis vaccine for the what is called the meningitis belt in Africa, though not every single country in that belt region requires it, but you still need it for some of the major countries there. And if you're traveling to Afghanistan or Pakistan, those two countries require the polio vaccine. And so in one way or another, some sort of confirmation that you were vaccinated has been required by the government, and you see it to today because of the COVID-19 emergency, right? Where we have this vaccine, highly effective, highly good at preventing severe disease, preventing hospitalization, and so the governments want to make sure A, that everybody gets it, and B, that if you don't have it, we can identify you so we can kind of keep an eye on you and keep you away from everybody else. Or vice versa, if you have it, then you're allowed to be more in crowds, etc. And so we arrived at this time now where the same things are repeating themselves. So the vaccine, there's a vaccine, it's being required. Certain people have access to the vaccine, certain people do not have access. People are being treated differently based on whether or not they have this vaccine certificate. It's being asked of some people, it's not being asked of everybody. And so, as somebody who follows the history of vaccines, I read all this and I am not. I'm disappointed, but I'm not surprised. It just keeps repeating itself. And so this is where we are now with the vaccine passports and the vaccine requirement. Everything old is new again.
Thank you so much, Renee.
Thank you.
We'll pass to Beth.
Thank you so much. I'm going to shift gears a little bit, and I'm also going to share my screen. I'm Beth Blower. I'm the Associate Vice Provost here at Johns Hopkins University for Public Sector Innovation. But most notably for the last 19 plus months, I've been working alongside Dr. Lauren Gardner as we have collected one of the globe's most precious data resources, which is the data that's been tracking COVID. The effort started off, as many efforts in our engineering department started off. This is a team that works on systems. We collect data all the time. Dr. Gardner has led efforts to collect data around a lot of endemic and pandemic level illnesses, everything from the flu to measles. And when this nascent disease started to appear, she actually had a grad student on her team from Wuhan, China. And together they thought they would start building out the infrastructure to collect the data. And in a matter of weeks, it became the kind of core source of COVID tracking data. We now are a team of about 30 people here on campus, where we've been leveraging across the board subject matter expertise from public health to vaccinologists, really trying to not only collect this data, but also to share it with sound public health information and trying to help guide everyone from individual people to policymakers around how they are responding by creating mitigation strategies for COVID. We started off with this very global view, but one of the things that I do in my daily work is working with local governments, and we really wanted to give a very local view here in the United States around the impact that COVID was having. So we replicated the data collection method for countries to collect the data at the state. And then we started collecting data at the county level here in the United States to give people here in this country a sense of how the disease was spreading, where we saw concentrations of disease, where we saw growth in disease, where we saw the disease abating, and really wanted to give a very granular local feel for how COVID was playing out in community. One of the things that we know about COVID is that it is a community transmissible disease. So our individual behavior affects the behavior of the virus. And so having some insights into how the disease is impacting our population became really critically important. And so we started to also want to share kind of the readiness of the public health system in this country to actually respond to this emerging disease. And so we created for every single county in the United States this sort of basic dashboard that gave viewers some really sort of distinct understanding of who their neighbors were, how they actually accessed healthcare, what the healthcare system looked like in their community. Not too many people prior to COVID would actually care very much about how many beds were in their hospital, or whether or not they had ICU capacity or ventilators, or they had staffing that would cover all of those beds. But all of these things became highly relevant when our critical health infrastructure was stretched. And so this data became really a corpus, not only to guide personal decision, but also to give those early warning signs around when we should be changing our personal behavior. We also wanted to look at demographic information. Early on, there was very little demographic information at all shared about who was getting COVID and who was dying from COVID. And we saw this as a critical missing piece of the story. And so we actually created this dashboard to just show people what general demographics look like in the populations across this country. And then we paired that with a call to action, where we said to states and local governments, you can't continue to collect COVID information without that sort of granular understanding of who's being most disproportionately affected by the disease. We knew anecdotally that Black and Brown people across the United States were being disproportionately affected by COVID, but that wasn't necessarily how it was manifesting in the data. And we started doing the storytelling, and it really took hold. We had an incredible demand on the data. This is a little bit of a visualization that just describes what that demand looked like. We had all of our data released to the public in open ways. We used a common license that was allowing for anyone to sort of suck up the data and use it. And use it, they did. We had at the peak over 4.5 billion calls to the data a day. We were getting at times 10 billion calls to the data, and we had over 1 billion visits to the site exploring different components of the data and the public health information that we were sharing. We were quite literally a viral sensation as it related to the information. But it was up against this sort of tapestry of information that was being contorted, that was fueling a lot of misinformation around the disease. And so a lot of the work that we've been doing for the last 18 months is trying to parse out information and share the data and set the record straight in many respects to some of the more dangerous narratives that we've seen being circulated through social media and through the public. So much and so that a sort of very nationally recognized brand or global brand ranking actually pinned us as one of the top 10 most recognizable brands, someplace where we had never landed before. But this just gives you a sense of how many people were craving a kind of steady hand in a stormy night when there was so much politicization of COVID data. We really did emerge as this sort of trusted voice where the data was just being delivered with kind of basic common sense, true to academic form of public health information. That being said, it was still something that we saw repeated in many ways and in different kinds of ways, sort of contorting the information and creating narratives. And so we started to take the data and really try to do our own analysis to walk people through in very basic language, using basic information, where we saw trends in the data that were troubling, where we saw opportunities to, like I said, do some course correction, but also to talk about what we thought were some of the most important levers over and continue to be the most important levers throughout this pandemic, which have been public policy and those mitigation strategies that are keeping communities safer and keeping families protected. But one of the hardest parts about that was this demographic data. We still are having incredible difficulties getting a sense of who actually is being disproportionately affected by disease. And as a result of that, we have a real hard time not only parsing out this information, but it is calling into question the way that we think about demographic data and the intersection of public health writ large. if we can't answer basic questions about our population, it does beg larger questions around how deeply embedded these elements of systemic racism are entrenched in our public health systems. The fact that there's so much confusion around even just understanding intersectionality in race and being able to talk about the fact that this is a disease that preys on people that have pre-existing conditions that have largely been divested of a public health systems. This goes back and calls into question the fact that we don't really know exactly what is the underlying reason, except for the fact that these are largely divested populations over a host of other public policy that's been developing in this country for quite some time. And so the reality of the situation is that this confusion, this inability to be able to actually think about who and how we are intersecting or how this disease is spreading, and not being able to really fundamentally compare interventions across populations because of this lack of information, a feature of the system or a flaw. And at this point, we have to really think about this as a feature. This table really represents one of the most glaring omissions of demographic data that there is in COVID, which is on testing. We know that there are massive impediments to getting testing as it relates to COVID. The data is explicit, but we don't know at all who is being really most disproportionately separated from the capacity to have the very basic information that will allow people to respond to those mitigation strategies, because this is showing you that the majority of states do not disaggregate their testing data by race. So we have used this platform of COVID to do a lot of advocacy, trying to really think about demographic data, but it is still incredibly difficult and hard to navigate. And it's one of the things that we hope is a significant lesson learned as it relates to the outcomes that we take away and the lessons learned that we take from COVID. Without it, we cannot identify who is the most vulnerable in our society. And that does not stop with a pandemic. That totally spans across all of the sort of social determinants of health, poverty, and the sort of safety net that we provide for residents in this country. There are also just another big troubling trend that we've seen, which are states where we collect the data from. All publicly available data that comes from states and local governments are starting to retract. They're starting to discontinue sharing that data on a regular basis and creating significant impediment to our being able to continue to do that tracking, which is another signal that governments don't see this as a long-term investment, don't see this shift to using more data to drive public health decision-making, but instead saw this as a short-term initiative, and they're very desperately trying to get the genie back in the bottle. So we are advocating for more standards around data use and the connection of data as we think about how we can create better public health systems that are evidence-based and that actually do serve all people and not just those who have the capacity to access it. So I'm going to wrap it up there, and I think I'm handing it over to Adam.
Yes, you are. Take it away, Adam.
Thank you, everyone, for these awesome presentations. It's a real honor to be here and super informative. The mission of the Electronic Frontier Foundation, where I work, the EFF, is to ensure that technology supports freedom, justice, and innovation for all the people of the world. This is especially hard to do during a crisis like the one we're living through right now. People are scared, and policymakers insist that new privacy-invasive technologies are the silver bullet that will save us. History shows, however, that plans to tech our way out of the crisis rarely deliver their promised benefits. They often undermine our civil rights and civil liberties, and most importantly, they are devilishly hard to dismantle when the crisis ends. To cite just one example, the NSA's surveillance of the internet backbone is still going strong 20 years after the 9/11 attacks. As the world has grappled with COVID, EFF has opposed many different kinds of plans to unleash novel surveillance technologies in the name of public health. The record of the past 19 months is mixed. I'll focus today on 3 issues: automated contact tracing, vaccine passports, and unregulated processing of our health data. When COVID struck hard in March 2020, we were all scared of 2 new threats: airborne transmission of a deadly disease and unprecedented isolation at home. Immediately came plans to create a new phone app that supposedly would kill both birds with one stone: automated contact tracing. It is labor intensive and time consuming to manually interview infected people regarding who they've been around. Tech developers asked, why not automate the process with a phone app? One proposal was to track our movements through our phone's GPS and cell site location information. But that cell data is only accurate to a half mile and GPS only to 16 feet. This is precise enough to invade our location privacy, like determine whether or not we went to a protest or a union meeting. But it is not sufficiently granular to show whether 2 people were close enough together to transmit the virus, the 6 feet cited by the CDC. Another approach was to track our proximity to others by measuring our phone's Bluetooth signal strength. If 2 people install compatible proximity apps and come close enough together to transmit the virus, then their phone apps can exchange digital tokens. Later, if one becomes ill, the other can be notified. Proximity tracking might or might not help at the margins. It will be over-inclusive. 2 people standing a few feet apart might be separated by a wall. It also will be under-inclusive. Many people don't have smartphones, especially among groups most vulnerable to COVID, like low-income and elderly people. Moreover, many people simply won't use a proximity app. Most importantly, no app can fill the need for traditional public health measures like vaccination, masks, testing, and manual contact tracing. Proximity apps must be engineered for privacy. Unfortunately, many are not. In a centralized model, the government has access to all the proximity data and can match it to particular people. This harms digital rights, yet many nations have adopted it. A better approach is Google and Apple's exposure notification system, sometimes known by the acronym GAEN or GAEN. It collects only ephemeral random identifiers that are harder to correlate to particular people. Also, it stores these identifiers in the user's own phones. If a user tests positive, they can choose whether to upload the identifiers to a publicly accessible database. Public health authorities in many US states and foreign nations sponsor these kinds of apps. Of course, participation must be voluntary. In short, automated contact tracing has not been a significant threat to digital rights in the United States. Unfortunately, the same cannot be said for vaccine passports. They have been rolled out in a manner that creates serious privacy problems. EFF is a digital rights organization, so we don't take a position on vaccines and vaccine mandates. On a personal note, my family and I got vaccinated based on recommendations from public health officials. EFF also does not take a position per se on requirements that people prove their vaccination status as a condition of entering certain spaces. This can be done, for example, with fewer digital rights concerns by requiring people to present their paper vaccine card or a digital photograph of their card to a staff person at a door. However, EFF does object to scannable vaccination credentials, like QR codes displayed on a phone and read by a QR scanner. It creates an infrastructure and culture that will be hard to dismantle when COVID ends. A system where we have to show our phones or some other marker to doorkeepers in order to go to a restaurant or go to the supermarket. Worse, this technology is ready-made to track people's physical movements through doorways over time. By adding just a few lines of code to a scanning device, it can record who walked through the door. With a few more lines of code, the data can be aggregated across doorways. We are not comforted when proponents of this technology say, don't worry, the scanners only will check whether a person was vaccinated and will not also collect or share personal information. We've been in this movie before. Some bars have deployed scanners to check patrons' identification cards to ensure that they are old enough to buy alcohol. Then these scanners were retrofitted to collect information from patrons and share that information with other bars. We're already seeing mission creep with scannable vaccine passports. The QR code in New York State system, the Excelsior Pass, is expanding beyond vaccine status to also include driver's license and health records. A company called Entrust, which works with the United Kingdom's national health system, wants to turn that country's vaccine passports into a national digital identification system. EFF has long opposed these kinds of systems as a one-stop shop for governments and corporations to track our movements and activities. There also are equity issues. First, scannable vaccine passports are expensive to develop and implement. For example, New York's Excelsior was supposed to cost $2.5 million, but now it's running $27 million, according to records uncovered by STOP, one of the sponsors of this forum. That's money we can't spend on bringing vaccines to people living in the margins of society. Many of the unvaccinated are willing to take the vaccine, but face barriers to doing so, which often correlate by race and income equality. Second, scannable vaccine credentials often require use of a smartphone, but 15% of Americans don't have a smartphone, including 39% of those older than 65 and 24% of those earning less than $30,000 a year, according to a Pew survey earlier this year. Proponents of scannable vaccine passports claim they are harder to forge than paper cards, but STOP found it easy to forge New York's Excelsior. In short, EFF urges policymakers to stop using scannable vaccination credentials. But in the event it proves hard to put this genie back in the bottle, we recommend safeguards. First, no one should be required to use a scannable vaccination credential. Gatekeepers must allow people to present their paper card or a digital photo of that card. Second, we need policy and tech design safeguards to ensure that scannable vaccination credentials do not track our movements. Third, we need open source code so we can look under the hood to make sure these systems work as promised. The final issue I will address today is the unfortunate lack of legal protections of our COVID data. Governments and corporations are processing all manner of our data, and existing laws simply do not secure it. For example, states are conducting manual contact tracing, often contracting with businesses to build new data management systems. Likewise, states are partnering with businesses to create websites where we provide our health and other information to obtain screening for tests and treatment. There are many ways to misuse this COVID-related data. Companies might divert it to advertising. It might be stolen by data thieves in foreign nations. Worst of all, public health officials and their corporate contractors might share our COVID data with police and immigration officials. This would frustrate containment of the outbreak because many people will share less of their personal information if they fear government will use it against them. Yet in some communities, police themselves are conducting contact tracing or obtaining public health data about the home addresses of patients. Existing data privacy laws are inadequate. For example, HIPAA and its protections of health data apply only to narrowly defined healthcare providers and their business associates. This does not include the public health systems being set up to address COVID. This is just one more illustration of why we need a comprehensive federal consumer data privacy law. In the short run, we need COVID-specific data privacy legislation, but efforts to enact it have stalled in Congress and the state legislatures. In sum, from the perspective of digital privacy, our COVID-era public health policies have been mixed. Glass half full, for example, our automated contact tracing systems are relatively privacy protective. Glass half empty, our vaccine passports include scannable credentials that create new privacy problems, and we lack adequate data privacy laws. We need to do better.
Thank you so much, Beth and Renee and Adam. Why don't you all join back in, turn your screens on, and we will have some a discussion about this. I have to say that a couple of thoughts occurred to me. First of all, Renee, I am old enough to have the little smallpox scar, and I never thought of that as like an identifying marker, as a vaccine passport of sorts. So you opened my mind. Beth, I was very struck by what you went through at Hopkins and how similar it was to what we went through at the New York Times. We started out just really with like one reporter, my colleague Mitch Smith, gathering data, and it's ballooned into this huge data gathering effort. We were the first news organization to report that there was a health disparity, a racial disparity, and the data, as you said, was very thin. Over time, we've gotten better and better at it. There was a demand. We actually won a Pulitzer Prize for it, and I just have to say, Hopkins has really been an invaluable resource for journalists. That visualization is really astounding. And Adam, I really appreciate the perspective that you have, sort of the cautionary words that like, let's not go crazy over this, and let's try to think clearly about what data collection can and can't do and whether or not it's worth it. And so with that, I would like to throw it out to each of you. My opening question was, what right does the government have to collect data on the individual in a public health crisis? And I'm interested in hearing from each of you, what right does the government have, and where do you draw that line? Is it an absolute right? Is there no right at all? And if there is a right, how do you figure out where it stops? So how about if we start just sort of in the order that you spoke, Renee?
Yeah, so I have the privilege to straddle different areas in this regard. My main work is as an epidemiologist, a senior epidemiologist at a county health department in the Washington, D.C. area. And so from the public health perspective of we need to know what's going on, we want to get as much information as we can, but also then I am also a private citizen. And I understand that there are things that I don't need to know about people so that I can help them, so I can help mitigate the epidemic, right? At the beginning, just like you mentioned, we knew that it was going to affect people who were marginalized, communities there was overcrowding. We pulled up the maps from the Census Bureau on overcrowding by census tract. And we knew where the pockets of this epidemic were going to be, without even having information on cases yet, because by design at that time, laboratories were not required to ask you for your race and ethnicity or even your address. All they needed was a doctor's order, and the result would go back to your doctor. And so it was hard for us to know where the people were located. But we had information on where we were probably going to see these things. And so we began the work there of going to those places where we saw overcrowding, where we saw marginalized populations, and began our work there. But, when we talk about the government having a right, from my perspective, is not that the government has the right. There are limitations on which rights of ours the government can interfere in. And as a private citizen, there are things that the government doesn't need to know about me. And people will often counter that with, well, what are you hiding? What are you afraid of? Nothing. It's just that, a healthy society is better if we have limits on what the government can do. That said, when people's lives are at stake, then there should be some framework, right, where we can expand a little more. And the case of COVID, where have you been? Who have you been in contact with? In the case of an STI epidemic, then who are your sexual partners? In the case of a food outbreak, where is your food coming from? What did you eat? Then it needs to be adapted in that way. And unfortunately, there's just no good way to do that without stepping on some limit of this. Again, we see this throughout history. We saw it in the outbreak in India, right? Only the people from India were being asked to show their certificates. Europeans were not. We see it with the smallpox eradication program. Who got their smallpox eradicated first? Western countries, rich countries. Disparities happen all the time, and unfortunately we're locked into this cycle again until, as Adam mentioned, we have to break that cycle. We have to find some better way of doing this.
Beth?
I think data actually can be part of the solution. I think it's obviously been part of the problem for generations. And so as kind of a central part of the problem, especially around a disease that is so like community based, you can't eradicate COVID without a community-based approach. And, you can spread it very easily if you have a community that's resistant to the kind of core mitigation strategies that, is going to be really effective. And so I think the concern that we have is that you also don't need to, have personally identifying information in the.
Can I actually jump in? I'm going to interrupt you right there because we're talking about contact tracing, right? So that in a communicable disease where we need to know who's passing it to whom, don't we have to have some personally identifiable information for that task? And continue on.
So I think it depends on the who in the question, I think. So with contact tracing, yes, we've had contact tracing in this country for decades.
Forever. Yeah.
Forever. It has been a part of our public health strategy forever. It has not been digitized. We have not had to really face the question about where that information is stored. It has been heavily regulated to really center privacy and to really protect those people that have been impacted by the disease that's being surveyed. So I think what the point that Adam was making was the right point, was that we were so desperate to try to scale contact tracing that we didn't center privacy in the ways that we have historically centered privacy. And so, yes, there is personally identifying information that's required, but we should not relent on the standards for protecting that information and for how we train contact tracers, how we think about the function of contact tracing and implementation, and center the person's privacy in the middle of it. And that is so what we saw is that some governments went directly to this digitization, where we saw a lot of corners cut and a lot of sacrifices made when it comes to privacy. And then some governments expanded that on the ground training of individuals that got the rigorous training that was required, that protected the privacy, that was really the person-led, and that information stays in the systems that were developed and built for contact tracing. That's a scaled model. It is a more expensive model. It is not an app that gets turned on and off. It is not something that can be fast or slick. It is literally my dad, who came out of retirement and took trainings and became a contact tracer here in the city of Baltimore. That is what he's doing now. He's been doing it now for the last 18 months. It is a human approach. And so I believe very deeply that the actual collection of surveillance data, though, does not have to be identifying.
Adam, I'm dying to hear what you say.
I agree with almost everything that Renee and that Dr. Blauer have said. When we talk about the balancing of privacy and public health in the context of these health questions, I think it's important to begin by remembering that often the two are not in tension. That studies from Ebola, from H1N1, from HIV/AIDS show that people who trust the government are more likely to obey instructions from public health authorities, and distrust is actually bad for public health. And that when there's a punitive surveillance-oriented approach from the government to public health, it can push people away and break that trust. I think when we talk about health data, that's a perfect kind of lens to look at a lot of the balances of privacy and public health. I think that the overall rubric for a group like EFF is minimization, meaning that public health authorities should collect, keep, share, and use health data as little as possible to accomplish their goals. And so, for example, with contact tracing, as Beth just explained, a certain amount of personal information has to be manually, carefully collected. Where were you and who you were in contact with? And then you go and talk to those people. There's no getting around that, and that's legitimate and necessary. But what happens with that data next? Does it feed into the surveillance-based advertising campaign of the corporation that built the database for the government to hold all this information? Is it transmitted to Immigration and Customs Enforcement so they can identify and deport immigrants? Is it kept in a database for 2 years where it can be stolen by foreign governments, just as millions of people's records held by the US government have been stolen by foreign governments? We would suggest for contact tracing data with a incubation period of 2 weeks, a month is plenty of time until the information in a contact tracking database is deleted. Now, if we're not talking about contact tracking, but we're talking about just general knowledge across America of where the hotspots are, clearly that's important information. I thought the system that Beth gave her presentation about seemed super helpful for public health. It did not raise privacy alarm bells for us because data collected at the county health level or at the county level is sufficiently aggregated that it's very hard to disaggregate and re-identify. Now, when you start getting smaller than the county level, it gets harder. Census tract data is really scary. Once you say age, gender, was sick at the census tract level, it becomes much easier to re-identify somebody. I think re-identification ought to be the scariest word in the language when it comes to public health data. One final thing I want to note, this was referenced at a very early point. There was some really interesting data that was emerging right after COVID broke out, where data was handed by people who collect cell site location information and phone app location information, showing, for example, that a bunch of people went to a beach and partied, and then all of a sudden they were all over America. That is really scary data that, from my perspective, should not be used at all by public health officials, even if they engage in rigorous de-identification of it, because it essentially COVID washes data that shouldn't have existed in the first place. We should not have an ecology of corporations amassing this hyper-sensitive, hyper-detailed information about all of our movements, dumping it into the marketplace where corporations are buying it for advertising and governments are buying it for policing. And then it gets kind of this, respect and legitimacy because it has potentially a public health dimension.
I'm curious what all of you think about vaccine registries and whether it's time for a national vaccine registry. This was an idea that came up in the Clinton administration back when they were talking about, when Hillary Clinton was leading an effort for a national healthcare program. And there was such an outcry over a national registry that, the whole thing collapsed. But to begin with, is it right for states to be collecting and gathering vaccine, vaccine data, and should, given that those databases are all different, do we need a national registry, or should we not have any vaccination registries at all, maybe?
So when we have an outbreak of measles, for example, at a school, we need to know who we need to keep home because they might be incubating measles and we need them not to go and be in contact with other people. Measles is highly infectious. At the same time, we have a very highly vaccinated population. That might not be a concern, right? I can tell you from my experience that after immigrating to the US, my shot records were lost and I needed to have the whole set of vaccinations all over again. And had there been more of a wider database, that would have been avoided. Of course, that's more of an inconvenience, right? There's no evidence out there that getting a whole set of vaccines all over again would really cause any damage. But what if, I had some sort of allergic reaction to one of the previous vaccines that my parents just kind of forgot about, and then it gets worse with the second round. That could be one of those what if situations. we do have in the United States populations that are highly migratory, right? We have migrant workers, you have people who are in the military service who move from one place to another, and then you have migrations of people because of opportunities and stuff like that. And so they need to take their paper records, and so we're now in this digital age of they're taking photographs of their records and showing those. I did that this past Saturday when I got the third dose for the Moderna vaccine. I didn't have my paper record for my first 2 doses. I showed the screen capture from when I got the first 2. So, this is the answer that we epidemiologists give all the time. It depends. It really does depend as to whether it should be a national registry. Again, it depends.
No, I think I have a mixed opinion on this one, just given what disarray the federal guidance has been just on data itself, and whether or not we feel like they can actually deliver on
they can't.
Vaccine registry.
I'm here to tell you.
I mean, I'm not as a, I'm just struggling because they can't even have define what a test is consistently. And so it gives me great pause to think about the kind of one of the things that we really pride ourselves on here is that we have a lot of governance. Every single piece of public data that we've released throughout the entire pandemic has gone through anomaly detection. We've been testing it. We've manually collected it. We understand where the data is coming from. We understand the limitations of that data. We are well documenting it. We've created an entire process around how the data functions. That's not being replicated in the ways that the data is necessarily being collected in other places. And so I have a little bit of pause there. And it goes back to even the kind of granularity that we would like to see in the data. We did see data that came out of some Utah counties early on in the pandemic that we thought would be identifying, that if we said in these counties that there was a case, that people would be able to do the kind of reverse engineering on the data. So we globbed together those counties and we made a very distinct decision to protect the identity of individuals. But that takes a lot of attention, a lot of discipline, a lot of best practice engagement. And so the question is, do we think it's good or something we should be thinking about now? It's a bigger question of whether or not those kind of investments in governance, investments in the sort of deliberacy that's required to keeping a resource of data like that safe, whether or not that discipline is in place before we even have a larger conversation around the application of it to a vaccine registry.
And as you know, as healthcare provider organizations are getting bigger and bigger, we might have something close to a national registry of our electronic health records. Right, that crosses state line, and so that needs to be looked into right away. The regulated and kept safe.
And we can jump off from there. I also want to talk, and maybe especially to Adam, about the role of corporations. During my reporting on these issues, I interviewed a number of companies that are like executives of healthcare IT companies that are working with state vaccine registries, and I was stunned to see that, they would say, well, you can go on my website, whatever ever MD, and pull up your vaccination record. So I would, go on, they would say, well, we have, we're working with Maryland and Virginia and this state and that state. And, I live in Maryland in the DC suburbs. And I went on the website and I plugged my name in. And boom, there were my infant measles vaccination records. They had a list of everything. And I was really stunned by that. And I said to them, well, how do you have this? And they said, we don't have it. You have it. So Adam, what were they talking about? And what is the role of industry in partnering with governments to collect health data?
What we have, which is not inherently a problem, is a once a century natural disaster that government with its own employees was not equipped to deal with. For example, building the databases necessary to process all the new health information. And so of necessity, and this is not inherently a problem, corporations who are experts in building databases and other technologies were brought in. And because the companies have the databases, the public health data being collected by the government goes to those databases. So far, so good. The problem is that there are no laws that adequately lock down that data so that it is timely destroyed, so that there are limits on what the corporations do with it, so there are limits on the corporations reselling it, and that there's adequate security to make sure that private or adversaries don't bust in and get the data. This rhetoric of we don't have the data, you have the data is, I would say, Orwellian. Obviously, they have control of a database. The government has a control of a database. All these employees have access to the database. Now you can look at it too. It also harkens to
one thing. I'm just going to jump in there. One thing I was really struck by was that these companies would argue, well, we're all about giving people control over their own healthcare information. Like without us, without company brand X, you, poor citizen, would not be able to access your own records this way. So aren't we doing something great for you?
Yeah, that's not really how EFF sees it at all.
I didn't think so.
I want to just jump backwards very briefly and hold up what Beth was saying about when they were doing data analysis in somewhere in Utah, and if they did it at the county level, it would allow a re-identification of someone. So they aggregated multiple counties together to have a big enough denominator that someone's identity was protected. Like that's just spectacular. That's what data privacy advocates like me want to hear. The problem is that there aren't laws on the books to make sure that the other actors are being as methodical and respectful as Beth is being with the data.
Yeah, I mean, that's, clearly something that we've seen even with government open data. I've been an open data advocate for a long time, but we've seen with a lot of irresponsible release of data, whether it's the New York City taxi cab data or some of the data that's been released around utilities, where it creates dangerous situations for people. And so there is a real risk when you're not being really thoughtful about the governance and release of public information. Absolutely.
I also wanted to talk about vaccine passports. Early in the discussion of vaccine passports, and I wrote a lot about this, there was a group of, I think, businesses that were arguing that the Biden administration should put forth guidelines on how to, make an appropriate vaccine passport. And the administration was really hands-off about this. I mean, they just do not want to step into this. It's a political third rail, and they did nothing about it. But I'm wondering, do you all think that maybe if we are going to have digital vaccine cards that people can access, is there a role for government in setting standards for what those what those apps ought to look like?
I think there's a role for government in setting standards. I think that we've been advocating for standards all along. But I think that, there's being responsive in standard articulation, like being responsive in creating a standard specifically for vaccine passports. And there's actually standard bearing for any digital capture of personally identifying information. And we need to start there. We need to have some clear leadership around what it means to actually create standards at a federal level and implement them evenly across the states so that they are widely adopted and that the right kind of governance is in place. I think the problem is actually the kind of ad hoc approach that people, that doesn't sound like a standard to me. It sounds like they want the government to scope a technology design. And that's a very different question than should there be a standard.
I have to confess, I carry around my little CDC vaccination card in my wallet. And, I've gone out to eat in restaurants that say you have to show proof of vaccination. And I'm frankly very happy about that. And I'm happy to show that proof. And part of me thinks what if my wallet gets stolen? What if I lose this card? What if it falls down in the river when I'm hiking or whatever? Wouldn't it be nice to just have some little thing here on my phone that I could just scan. But Adam, the way you talk about this, it sounds very dangerous to me. So, what do you think?
I don't know if you can see this on my phone here, but like I literally took a picture. Well, you can't see it. I took a photograph.
I took a picture too, but what if my phone falls in the toilet, you know?
Well, who has access to your photos? You give permission to every app in the world to have access to your photos.
Yeah, I have everything backed up to the cloud, so it's in the cloud.
It's a free for all.
So Adam, what's the answer?
For EFF, there's a difference between a photograph of a vaccination card, which is in the cloud and accessible to everyone who can get your stuff in the cloud, whether it's the Russian hackers or the abusive employee of the cloud company, on the one hand, versus a scannable QR code on the other hand. And precisely the difference is when you walk by the maitre d' and show them a photograph of your vaccination card, they look at it and say, oh, you're good, you can come in. Whereas when you show your QR code and the maitre d' holds up a QR scanner and zaps your phone, with a few extra lines of code, it can make a record that you were there. And with a few more lines of code, it can send that information to other people. And what we'll end up with is what we have in China, where people are showing the QR code on their phone to a scanner on doorways all across the country. And this information is feeding into the dossier of information that the government collects on people. And in the context of COVID, was having an influence on whether people were allowed to do various things, because it was part of their model of people's health risk. And from the purposes of keeping people in the restaurants safe, and for the purposes of defeating forgery, I think the paper card or the photograph of the paper card are as good or nearly as good as these QR codes, which again, STOP, who is sponsoring this event, hacked in 11 minutes. So the health gain of the scannable QR code is very small, and the privacy risk of the QR scannable code is very high.
Renee, I'm curious about vaccine mandates for schools, given what you know historically about state mandating requirements for measles and mumps, et cetera. I'm curious what you think about schools mandating coronavirus vaccination.
It's up to the individual schools. I can tell you, even in places that look blue on the political map, like Maryland. Within Maryland, there are school districts that are not requiring them because the school districts led by the parents are not asking that. I think not asking for those vaccines. Is it a good idea? I leave that up to history. From the scientific perspective, it's just as safe as all the other registered and licensed vaccines. It's highly effective. It benefits us more than anything. So public health, scientifically, very good idea, right? As to whether or not they can be mandated, well, that's then we begin to get into the fuzzy area of like, well, I have a 4-year-old child, how much of her autonomy do I want to give over to the state? Not a whole lot, but at the same time, I understand that there needs to be that requirement on her to keep her schoolmates safe. So it's going to happen. It's happening. It's probably going to become one of those vaccines that stay with us for a few years while it becomes endemic, and then it probably will go away. Just like the other, in case your audience doesn't know, there's 4 other human coronaviruses that are nuisance viruses, and I think from everything that we're seeing, this one is going to become a nuisance virus as well. And then it'll go away. Smallpox vaccine has gone away. Polio vaccine is about to go away because it's about to be eradicated. Measles is another one that could go away if everybody followed the requirement for vaccination. So good idea, bad idea. I don't like to think in those dichotomous ways. As a parent, good idea. I want my daughter to be protected from infectious diseases. As a private citizen and a father, I don't know if I want to hand over that much autonomy to vaccine requirements at a level that at a much grander level. Yeah. At the school level where I can talk to parents, I can have that discussion, but something, big up there, it's kind of hard. It's hard to do, and I understand people who have that apprehension.
And I think there's also on this point a difference between emergency use, and we are still for kids in an emergency use authorization versus one that has the full faith and, but not that I'm not doubting that it's a very safe and effective vaccine. I'm just saying that having a mandate before we've moved out of emergency use, I think is something that will only fuel the sort of hesitancy that we're seeing, the legitimate hesitancy in many cases, whether that's cultural hesitancy or religious hesitancy. And so I think that there's also a question of what the timing should be.
Yeah, I think that's absolutely right. And we saw the Biden administration imposed vaccination mandates only after the Pfizer vaccine was granted full approval by the FDA. I wanted to remind people that you can put some questions, if you have any, in the Q&A. You can't unmute yourself and talk to us, but you can write your questions and we will look at them. We've got, I think, maybe 10 or so minutes left. I also wanted to talk about lessons learned. What do you think are the lessons that we have learned from this, health crisis and what I think is fairly described as kind of this mess of data gathering? Have we learned anything? And how will we do it better the next time?
I know I definitely have learned a lot. I think that, I think the jury is still out on whether or not political leadership has learned. I think what we did see was that people were really seeking information, unbiased information to guide these personal decisions. I know for the very first time, my parents understood what I did for a living, because it became like immediately relevant. I never ever would imagine that my sixth grader would be talking about flattening a curve or any other statistical concepts. I think that we've all collectively done so much living and learning in the last 18 to 22 months. And so I think that that's going to be some momentum that we are going to be expected as a system to continue. So what does that mean? Does that mean that we go back to the status quo where we're making black box decisions around the health of our communities without sharing the evidence base as to why we're making those decisions? Or are we going to continue to have a messiness around the way that we describe our communities that makes it nearly impossible to actually create targeted interventions that will help to resolve legacies of discrimination and bias and deep systemic embedded policymaking? I hope not. I can't imagine coming out of this and thinking that we can go back to that kind of status quo governance and thinking about government. But, we're seeing it happen before our eyes. We're seeing states that are clawing back. And I think that we just need to really think about what that means and how we can hold the system accountable in a way that doesn't allow it to happen.
Right. Melanie writes and reiterates the question I asked, which is what about planning for the next pandemic? What is the next chapter for data gathering in public health? The next chapter, in other words, what can we do to prepare for the next go around? Should for instance, should there be an overhaul of the way the CDC gathers information? It seems that to my way of thinking, their systems are very antiquated. We haven't invested in public health information. It's been left to this kind of patchwork. It's been left to private entities to sort of fill in the big data gatherers, I can't remember what their names are, Epic or some other big companies. What, as a society and as a government, how should we be?
I think there's also a hesitation, particularly at the CDC, to create standards and to actually build the evidence base in a way that's consistent across the states. And what we learned in the last 18 months is that the states are craving it. They didn't know how to talk about this data. They didn't know how to collect their own data. They were desperate for guidance. I'm sure they called the New York Times, just like they're were calling Johns Hopkins University to say, like, just tell me how to collect it, or just tell me how to publish it. Like, I just need to know, because they were not getting that kind of guidance. And so I do think that there has been a real sort of shift in this sort of expectation that the locals have it, to no, we as the federal government do need to be, and the hospitalization data is a really good example of that. They created a standard around how we should measure hospitalizations to try to really understand the fall surge. And it was a pain in the A for hospital systems.
I know. I wrote a lot about that.
But at the same time, it was like the best data that we got throughout the whole pandemic. And that's because they created a bright line, and then they said that you've got to collect the data in that way. And so I think
sorry to cut you off. Some great questions though in the Q&A from an anonymous attendee. And Adam, this is for you. How do we discuss these concerns with friends and family without sounding like a conspiracy theorist? Are you a conspiracy theorist?
I only theorize the true conspiracies and not the false conspiracies. It has been a bit of a struggle for EFF because there has been, unfortunately, a kind of partisan alignment where one side is in favor of every mandate and every method of enforcing it, and one is against every mandate and method to enforce it. Whereas we in the EFF, a lot of this, we're a digital rights group, so we don't speak to mandates. We don't speak to whether or not you should have to get vaccinated to enter a restaurant. But we do have concerns about new technologies that can cause new harms. In terms of how to, avoid sounding paranoid, I think, we just speak to shared principles like safety and privacy, and talk as much as we can about the facts and the record of a lot of excesses being used in various crises, both medical crises and other crises that, when we look back on them, we're like, well, did we really need to, criminalize transmission of disease? In the 1980s with HIV, that was a overreaction. Let's not make that mistake again.
So, and here's a question from Mauricio Garcia. What new investments are being made in health access and literacy as a result of the last year? I don't know the answer to that, and if any of you do, please speak up. But I do think it's a really important point that we've all been awakened to a new language around health, and yet we have seen these terrible disparities. And so what investments are being made or should be made in access, and also in people's understanding of what public health is and how they need to protect themselves. So I'm going to throw that to you, Renee.
Yeah. So in the History of Vaccines project, we try to not include a lot of jargon, and we try to make the language as plain as we can, and we translate it to different languages, because we want people to know the history of vaccines, and we don't advocate for or against vaccines. We just put the information out there. We've talked about vaccines that have been taken off of the market because of concerns. We talk about vaccines that, the fact is that they're safe and effective. And we do this as best as we can. One of the things that we did notice was a spike in the number of visits to the site of people asking for more information. And whenever I saw on the news people saying, "Oh, the mRNA vaccines are the fastest vaccines made," and I was like, "No, that's not true. That technology has been around since the mid '90s." And that kind of information, it signals to me that people are not very well aware of what's going on. On the other hand, who has time with everything else that's going on with the economy, with the pandemic, with having to take care of children? Who has time to understand biology and understand physics, about chips in vaccines, or understand immunology of how antibody levels do not necessarily correlate with immunity, that kind of thing, And so it's very, very hard. I think we need just more investment in STM education for our children, and emphasizing at every stage of the educational cycle what all of these things, how they all correlate with each other. We need to just have more of these programs like big plug, historyofvaccines.org. But all of our partners, we got together with the Children's Hospital of Philadelphia to talk about vaccine education for parents. And then so there are niche little things that we can educate the public on. We cannot rely on movies teaching people what the R naught is, or politicians teaching people what the herd immunity threshold level is. Those are things they're simple math, and if you lay it out for them, they will understand. And we cannot let YouTube or Facebook or any other social media be the way that people get their information on these things. Unfortunately, I think somebody once said, the death of the expert has come and gone, and there's no more experts. Everything is subjective now. But we can take it back. It has happened through history that we find a way to get people back into understanding the science and technology that goes into advancements. We cycle through all these histories.
I think it was you, Adam, talked about HIPAA. And I'm wondering, do we need new laws passed around? I think you did say we need new laws passed around healthcare and data privacy. So what would those laws look like? And I'm curious, who are your friends on that issue on Capitol Hill? Who's carrying legislation in this area?
Yeah, I think a lesson learned of the health crisis the last 2 years is that we need better consumer data privacy laws that would include medical records outside of the narrow scope of what's protected by HIPAA. There are many legislators from both parties who have supported legislation in this space. Unfortunately, there's kind of a gridlock, like everything else is, surrounding whether it's going to be enforceable and whether or not it's going to preempt all of the state legislation. So there probably will not be a bill soon, but the kind of things that should be in it would include, like I said earlier, that companies who are processing personal information should minimize doing so to what is really necessary to the public health need or whatever the particular need is. It might look something like the European Union's General Data Protection Rule.
On that note, I'm going to pass it over to Melanie. Sadly, we're out of time, but I want to say thank you to all three of our great panelists for such a great conversation. And Melanie, over to you.
Thank you so much, everyone, for this amazing conversation, which has been so informative and so accessible, which I think really speaks to one of the last questions that we had. And I really appreciate seeing the landscape of these historical examples and the learning from our current moment. And we've been grateful to share this conversation with all of our registrants today. And we will also be sharing this conversation and all of the other 5 conversations from this speaker series online in our archive in the coming days. I want to also thank all of our colleagues who've made this series possible, especially as my colleague Constanza Valenzuela, working tirelessly behind the scenes to make this possible, Tucheli Alamani and Marisa Garcia, who are here as well, who have supported this program from the very beginning, as well as our advisors who've been guiding all of our public engagement around Sam Durant's Highline Plinth program, the Center for Constitutional Rights, the Immigrant Defense Project, Media Justice, Mi Gente, Empower Change, and Reprieve. A quick shout out to the members of the Highline Plinth Committee, contemporary art leaders committed to realizing major commissions and engaging in the public success of the Plinth who made this series possible. And of course, thank you to everyone here today. So after this final conversation for the Normalizing Gaze, Surveillance from Drones to Phones, we will be looking forward to hosting our second symposium, which will take place in February next year. We'll be concentrating on the subject of the drone itself, more of an international perspective through a number of panels, performances, and conversations hosted with the Vera List Center at the New School and with writer and researcher Arthur Hall and Michelle in spring 2022. So do not fail to sign up for our newsletter. Constanza is putting in the chat right now to keep in touch with all of our upcoming programming and the continuation of these conversations. So thank you again to our panelists, Renee, Adam, and Beth, and to our incredible moderator, Cheryl. Thank you for guiding us down this path. And to everyone tonight, good luck, good night, and we will see you next time. Be well, everyone. Thank you.